So I'm going to talk to you about teamwork and obstetric emergencies, but just before I start, I want you to consider something extremely simple. It's an ATM cash return. Now, the obstetricians in the audience will immediately recognize the denomination notes that are here. They're 500 euro notes. But I needed to point that out for the poor anaesthetic and midwifery staff that are here. It's a really simple task that we do, maybe not every day, but certainly every week or so. And I just want you to consider the situation when ATM machines were introduced, that cash was returned first, because really this is the objective of the exercise. And it did produce a typical woo-hoo type response, but it was very quickly noted that there were problems. The big problem was that people often left their card behind in the machine. So that's been changed, as most of you will recognize. But it is interesting that this data is from AIB, so it's only related to AIB bank machines. More than 10,000 transactions per annum cash is left behind. And that amounts to more than €1 million per annum. You may be surprised at those kind of numbers because they seem genuinely very, very big. But I'm much more surprised at the fact that this is a really simple cognitive error. It's an error committed by somebody who's capable of performing the task safely. They've often done so many times in the past, and they face significant personal consequences for that error. And that's very, very important. It represents the human condition. It represents human error. And it is important that we remember when we're talking about patient safety that human error is ubiquitous. It's absolutely ever present, and it's unintentional, and that is important. Just keep it in mind, not for that simple situation of an ATM cash return, but in the setting of the complexity of a medical emergency, in particular a medical crisis. The usual outline slide, we'll move on from it from a time point of view. What is the scope of the problem relating to medical error? Well, it's very, very significant. Many of you will be familiar with this publication, which is from the Institute of Medicine, produced by Harvard in the States, that indicated that probably 44,000 to 98,000 deaths per annum just in the United States are directly related to medical error. That's 44,000 to 98,000, and nobody's getting excited about this, but with less than 3,000 Ebola deaths, the whole world is on high alert. If you extrapolated those incidents to the Irish population in 1999, it amounts to about 600 to 1,300 deaths per annum. Again, these are deaths of real patients. And just to put it into context, there were 442 deaths reported from commercial aviation fatalities in 1999, which included big events like the Egypt air disaster, possibly related to pilot suicide. So it really is a big problem. What are the causes of it? Well, for safe task completion, you need to do a couple of things. There are things that are related to technical competencies, so things like procedural knowledge relating to anatomy, physiology, drug use, whatever, and also psychomotor skills, and you've discussed lots of things like rotational motor skills and stuff to be able to deliver shoulder dystocia baby. But in actual fact, there are lots of non-technical competencies that we need to use in our work day to day, and they're cognitive skills in relation to decision-making processes and also social skills with regard to communication. Pilots, in fact airline industries more appropriately probably, have known this for many, many years, and over a number of decades have introduced cockpit resource management to try and deal with non-technical errors, which they discovered were probably the majority cause rather than technical failure. So it's very similar to our ATM example from before. In recognition that it's not just a problem that resides in the cockpit, they've moved on to crew resource management and more recently to crisis resource management. And crisis resource management, probably since the early 1990s, has been applied to acute medical specialties, primarily anesthesia, emergency medicine, intensive care medicine, but it's probably becoming a feature that we need to expand to other settings, and particularly multidisciplinary obstetric emergency training. What does it mean? Gosh, there's like about 3,000 hits for a definition of crisis resource management if you look on Google. This is probably the most sensible definition, which is the ability to translate medical knowledge to real-world actions in the setting of an emergency. So it's quite a simple definition, but I think nonetheless important. What are the features of crisis resource management? I've chosen 6. They're adapted from a list of 17, anesthesia, CRM principles. It seems to change all the time, and like most things, it just expands rather than retracts. But I've picked six principles to talk about today that are certainly related to teamwork competencies, and they're shared maybe in other scenario-based training settings. Effective communication is probably the one that underpins absolutely everything else. And I know that some of the anaesthetists in the audience have been to anaesthesia and non-technical skill training recently, where they're trying to, a group in Scotland are trying to provide a taxonomy for describing non-technical skills and teamwork skills in medical education, and they actually haven't included effective communication as one of the taxonomies because they consider it so important that it stands alone in and of itself and underpins absolutely everything else. The other things that I've chosen to talk about are leadership and followership, use of all available resources, and we've seen lots of nice diagrams, algorithms and flow charts today that are helpful for cognitive aids, things like drug use, drug doses and stuff like that. They're incredibly important in the setting of a medical emergency. Situational awareness is something else that I'll talk about. And then maybe two things that are really considered maybe the softer social skills, but probably some of the most important, and that's shared decision making in an emergency in a setting of mutual respect. The ones that are starred are those that are common to other scenario-based training, so they're the teamwork elements that are dealt with in the initial chapters of the prompt provider manual, of ACLS manuals, and such like. So what about effective communication? Well, if you've done ACLS training, you'll know all about closed-loop communication, which is a military strategy that was designed as a verification strategy to make sure that the message sent was received and interpreted as intended. Very useful in ACLS, in the setting of maternal arrest, perhaps. Very useful in the military, but if you start using this as a communication tool for absolutely everything that you do in your clinical practice, most of your colleagues will think you're stark raving mad. So probably something that is much more useful, that has been mentioned already today, is a structured communication tool. This app, I've actually accessed it today to make sure it's still available through iTunes and Android stores, is an ISBAR app that provides that structured communication, and it is available free to download. You can do it now, or maybe wait till the end of the talk would be nicer. It does give a selection of patients to choose from, but helpfully it does relate directly to obstetrics and gynecology patients, and it goes through an introduction or identification process, a situation to give some kind of background, then an assessment of what's going on, followed by a recommendation of what needs to happen next. Whether or not that's a specific drug treatment or somebody else to help and come and review, it certainly is very, very important. ISBAR is not only mentioned, but encouraged in other HSE guideline documents, including the documentation that comes with early warning scoring systems, to really encourage bedded in structured communication processes. So that's available. There's quite a bit of information on it in the National Early Warning Score Guideline, but also in the COMPASS training manual for acute medical emergencies that accompanies it. For those diehards among you, there is a new National Clinical Guideline for communication in maternity services in Ireland specifically, but it's really just for those diehard people who are willing to read 295 pages of it. Probably some people will, but probably the documentation that's available in the early warning score guidelines is sufficient just to get the gist of ISBAR if you are not used to using it. So that pretty much provides maybe some structure and communication and something that we can actively teach and lead by example in using in our day-to-day practice. Leadership and followership issues always part, obviously, of teamwork. They really clarify roles and responsibilities in an emergency, but also cover things like knowing limitations and asking for help early, providing mutual support, and cross-checking is very, very important, obviously, in an emergency. All available resources, we've talked about some cognitive aids, possibly other elements like point-of-care testing, but also human resources are very, very important. Situational awareness addresses the what, so what, and now what aspects of an emergency. And there is some overlap with some of the other teamwork competencies in terms of information gathering, understanding and anticipation, but it does allow you to plan ahead what's going to happen next and prepare for it. So for example, we train in this way for shoulder dystocia deliveries and make sure that the anaesthetist knows that it's likely to be followed by a postpartum hemorrhage, so they need to be there too in anticipation of that. Provides the helicopter view from the end of the bed about what's going on. The other aspects of CRM, as I said, the softer skills so-called, are in relation to mutual respect and are designed to break down the hierarchy that exists in our normal clinical practice. And hopefully will encourage everyone to treat input from other team members legitimately. Shared decision making, the Irish are absolutely brilliant at doing a hint and hope, even in the most dire of clinical circumstances. And we really need to be much more clear in terms of what we want from a decision-making process. Certainly you can express your concerns in terms of an SBAR type structure. Airline industries use critical language, so I'm concerned, I'm uncomfortable, or this is unsafe. So they're allowed to use cuss words. It could only be American Airlines who introduced that one. So that's them. I think their core principles, I think they are truly multidisciplinary and multi-professional in an obstetric emergency setting, and I don't know that it's helpful to add in other elements of teamwork training or crisis resource management and make it too complex to be useful in a clinical setting and in a teaching session particularly. It's likely that they are to some degree domain specific, so to some degree they depend on the particular emergency, the particular team involved and the particular patient. So not all of them will be applied right throughout the board maybe. Mostly when you teach these principles in general, there'll be good face validity. So people genuinely seem to enjoy training that involves teamwork or CRM training, but just because they enjoy it doesn't mean that it's very good. So we do need to look for some evidence of construct validity. That's the translational science element to make sure that that teaching and training is effective in the real world for real patients. So, does it work? Well, there is evidence for success, and primarily that evidence comes from Southmead Hospital in Bristol, where they introduced prompt training many years ago. The benefits are there for mum, but more particularly for neonates. I won't go through them in any detail. It also works in Boston when you implement these teamwork training courses. They all have an element of skills and drills with them. Again, reduction in adverse obstetric events, reduction in litigation, and labour staff have more positive attitudes to safety. Works in Liverpool, pretty much exactly the same as the prompt training regime, and good neonatal outcomes again. It also works in Copenhagen. I think this is interesting that it certainly improved staff confidence scores in terms of dealing with emergencies, and that's the face validity that I spoke about earlier. But it also was associated with a 45% reduction in midwifery staff sick leave, presumably reflecting how less stressed they felt in dealing with these emergencies in work. So there are other maybe hidden benefits of implementing team training. So that's great. So what we should do is maybe do a little skills and drills course and just do a bit of team training and it'll all be all right. Well, the evidence still really sits with association rather than causation. And there are lots of other elements that are there in the background that are probably as important as whatever specific educational intervention that you apply. Certainly things like institution level incentives for training, and a positive safety culture, a non-threatening training environment, realistic training tools that are reasonably high fidelity, and people have spoken about things like birthing mannequins, maybe simulator mannequins and things like that. It should really be relevant in-house training, and there is a benefit to training in these skills and drills and teamwork elements within your unit, in that it allows you to find workable solutions to problems that you encounter that may not be replicated in other units. There are also self-directed infrastructural changes, that's local solutions to difficult problems that are revealed with that in-situ training. And it's certainly universally positive reports from this type of training have absolutely been multi-professional and involved everyone who is involved in patient care in that department. So what do we need to implement such a training structure here in Ireland? Well, there are lots of things that we have that are extremely useful. So we have a number of guideline documents that relate to obstetric emergencies. So we do have quite a bit of peer-reviewed evidence there that give us guidance on the management of these conditions. Certainly the Compass training manual is available on the HSE website. It's a general kind of manual with regard to the initial management of the significantly ill patient and available for use by absolutely everybody. It's being rolled out certainly in the Mater Hospital with nursing and intern staff. I think the consultants were told last week that they all had to complete it, which I'm very looking forward to some of my colleagues getting there. News guideline, certainly there is a resource for you, and things like the ISBAR app and obviously the ONG Ireland app that are there as well. In terms of personnel who need to be involved, well, obstetric, midwifery, anaesthesia, but lots and lots of others, again, depending on what specific emergencies are there. And I think somebody mentioned earlier on, certainly Dr. Higgins mentioned portering staff, and I know that for anyone who's worked in the Rotunda Hospital, Dennis, the theatre porter, will pretty much get anything you need done. He should be running the country. So all of those people are very, very important to the safe care of patients and the delivery of this type of training, and therefore they need to be involved in the drills as well. Simulator mannequins can be used, birthing simulators, sometimes with force monitoring to describe what's going on, and maybe resuscitation mannequins for the type of BLS training that would be part of this as well. And in terms of measuring how good we are, I don't know that we'll be able to provide very effective resources to show the kind of changes that have been demonstrated in the Bristol unit, in Liverpool, in Boston, and other places like that. I think it will be important to provide face validity satisfaction scores to demonstrate that it is an enjoyable training experience for people, because that is important for them to engage. But I think it's possible that we will be able to run rolling audits in individual units, probably very much unit dependent and hopefully supported by the HSE, to demonstrate if we're making a difference with this kind of training. How do I see it working out? Well, I kind of have an image in my mind of a train the trainer type program that would include all of these teamwork elements, and then maybe some skills and drills being delivered either at a regional stroke network level and in the individual maternity units as well. Not all scenarios will have to deal with all of the teamwork competencies. Just to finish up, because communication is so important, think about it when you go back to your unit and use ISBAR, but I'd be very willing to take questions on ideas that people have to implement this kind of training in Ireland. Thank you.